Hi, this is Herb Kressel, and welcome to the November 2015 Radiology Podcast. This month we have discussions on three provocative manuscripts. First, I'll be interviewing Dr. Matthew McGinnis from the University of Ottawa, who, with his colleagues, performed an interesting systematic review on the accuracy of gadoxetic acid-enhanced MRI in the diagnosis of focal nodular hyperplasia and hepatocellular adenoma. They came up with a rather interesting result that shed some important light on the issue of disease classification and the role of systematic reviews and meta-analyses. And next, my colleague, Dr. Alex Banquier, a deputy editor for thoracic imaging, will be speaking with Dr. David Yankelevitz, who, with colleagues from the International Early Lung Cancer Action Program, provided a provocative report on the screening of non-solid nodules in baseline and annual repeat rounds. They have some rather interesting findings to discuss with Dr. Banquier. Finally, my colleague, Dr. Albert DeRoos, our deputy editor for cardiovascular imaging, will be speaking with Dr. Michael Brand of the University Hospital at Erlangen, Nuremberg, on their paper on the influence of cardiac MRI on DNA double-strand breaks in human blood lymphocytes. As you may know, there's a controversial article published by another group noting the presence of these breaks and speculating on the safety of cardiac MRI. This report has somewhat differing results, and I think you'll find the discussion very worthwhile. As always, we welcome your comments and thoughts on this month's podcast. Hi, this is Herb Kressel, editor of Radiology, and welcome to the November 2015 Radiology Podcast. Today, I'm delighted to be joined by Dr. Matthew McGinnis, who is Associate Professor of Radiology in the Department of Radiology at the University of Ottawa, and that actually served as our Eiler Editorial Fellow last year. Welcome back to the journal, Dr. McGinnis. Nice to see you.
Great to see you, Dr. Kressel. Thanks very much for having me.
Great. And today we'll be talking about a paper that you and your colleagues wrote on the accuracy of gadoxetic acid-enhanced MRI for the diagnosis of focal nodular hyperplasia and hepatocellular adenoma, a systematic review. And I thought this paper was interesting both from the methodology you used, and I think the findings were very provocative. So why did you and your colleagues think that this was an appropriate topic for a systematic review or meta-analysis? How should people go about conceptualizing when to do this type of study?
Well, I think the fundamental aspect of systematic review and meta-analysis that doesn't differ from any research is it derives from clinical uncertainty. So really what drove this paper was several of us in our abdominal imaging group sort of disagreeing with the usefulness of this contrast agent gadoxetic acid for diagnosis of FNH versus hepatocellular adenoma. And I was on one side and my two co-authors were sort of on the other side, and we were each picking random papers to sort of support our hypothesis. And we noticed that no one had sort of summarized these papers in order to provide maybe some overarching guidance on how useful it was, and if there was variability in the reports for usefulness, could we identify reasons for that variability? So that's sort of what drove was the genesis for the question, and the disparate reporting with lack of a single large dominant trial and conflicting findings was a reason we thought it might be appropriate to look at with systematic review.
Now, when you began your work, did you know whether you'd be performing a systematic review or a meta-analysis? Is it useful, do you think, to have a clear notion of where you're going before you begin, or can you really decide?
I think that's a great question. So if you look at our study protocol that we registered on a registry called Prospero, which is available for systematic reviews, you'll note that we stated we planned on doing a meta-analysis if we deemed it was appropriate. And the question of when it's appropriate to pool your results to get a summary estimate of sensitivity or specificity, for example, is a challenging one. And often you have to look at your data before you decide if it's appropriate to pool or not. Now, whether you pool or not is often based on whether you think the studies are similar enough that combining the data to get a summary estimate is going to be meaningful. If you have, let's say, 5 studies and half of them have sensitivities of 100% and half of them of 40%, you could pool and get a summary estimate somewhere around 65-70%, but that wouldn't be a meaningful estimate because it would really be dependent on factors driving the heterogeneity between those. So we planned on potentially doing one in certain scenarios. We eventually found that our data was a limited number of studies, or about 6 studies included, not a huge number of patients, and a lot of study level heterogeneity that we could observe. So we thought it wasn't the best idea to pool the data, but look at reasons for why the heterogeneity existed.
I see. Now, you in your manuscript, you formulate and clearly state a PICO or PICOS question. What was the question that you framed, and why it is important to clearly define a PICO question when you're doing this type of analysis?
That's a good question, and I think like any research, you want the reader to know to whom the research question applies. So you want to know what the patient population is. So that's the P in PICO. So we said adult patients without a history of chronic liver disease who have a potential diagnosis of FNH or adenoma on liver MR. So it really frames the question for the reader. We're not talking about patients with cirrhosis or with a known primary that's known to go to the liver. So it's sort of a different patient population than some of those. So the reader can frame the question and say, do the findings of this study apply to my patient population? Now, the I of the PICO question is the intervention, or in our case, it's really an imaging study, and that is the MRI done with gadolinic acid, or people will know that as Eovist or Primavist, depending on where you work. And we had to specify exactly what the MR was. So it was an MR with this contrast agent with at least a 20-minute hepatobiliary phase delay, so that, again, the reader will know, okay, I do this MR in a similar manner, therefore the results are likely to apply to my population if it matches how I do the MRI. Now, the C in PICO is often dropped in imaging systematic reviews because we may or may not be comparing it to another imaging study or another intervention. So we dropped it in this case in that we're purely looking at diagnostic accuracy for this imaging study, and our O is outcome, and in our case the outcome is what the final diagnosis is as judged by a reference standard. So the outcome was whether the diagnosis was for focal nodular hyperplasia or hepatocellular adenoma. So that's a brief description of how to frame a PICO question, but there's a great paper by Staunton in Radiology from, I think, the early 2000s that describes it in a lot more detail.
Mm-hmm. Thank you. Now, you also included case reports, and I don't recall seeing a lot of case reports in systematic reviews and meta-analysis. And why did you decide to include them, and what did they actually add?
Well, that's a good question, and I think a lot of purists in systematic review might disagree with that, and there's probably room for disagreement in including those. Now, we included them as sort of a secondary analysis. The reason we decided to include them is because we thought they offered an opportunity to provide maybe some hypothesis generating information. So these case series had a number of cases of hepatocellular adenoma reported on gadolinic acid MR, and several of them reported much higher rates of hyperintense hepatocellular adenoma than had been reported elsewhere. And they offered an opportunity to look at why these case series differed from these larger trials that had FNH and hepatocellular adenoma. And they really offered what I would say is a hypothesis generating opportunity, in that they didn't allow us to form firm conclusions, because obviously a case series isn't the most rigorous scientific exercise. But given that the primary studies we included were fairly small and heterogeneous, we thought it was appropriate to include these at the very least to frame a discussion on forming future research on this topic.
You see. Now, let's get to the meat of the matter. What did you actually find? What were the results of your systematic review of gadoxetic acid enhanced MRI in this population of patients?
Sure. So that the primary outcome measure was really what's the diagnostic accuracy of gadoxetic acid for diagnosis of hepatocellular adenoma versus FNH. And from the primary studies, we found the diagnostic accuracy is pretty high, with sensitivities and specificities ranging in the 90 to 100% range. We didn't do pooling to get a summary estimate, but we noticed that the lower end of the confidence intervals for sensitivity was about 77%, and for specificity was a bit lower, down to the 50% range. So because of that quite wide variation, we didn't do pooling, and we decided to look more closely at what the reasons for this variability were. And I think one of the main outcomes that we found was that the application of reference standards differed from study to study. So the reference standard being the diagnosis of hepatocellular adenoma and how it was made. So those who are familiar with, up to date on cytogenetics for hepatocellular adenoma will know that they're not just one entity anymore. There's 4 main subtypes, and one of those being the inflammatory subtype of hepatocellular adenoma that makes up about half of cases. Now, the tricky thing is this new classification has only been generally accepted since about 2011. So we found that only one study among our primary outcome studies had done molecular subtyping to classify these lesions. And the tricky thing is that if you didn't do molecular subtyping, often you would have classified what's an inflammatory hepatocellular adenoma as an FNH, and we used to call these telangiectatic FNHs. So this recategorization actually put what used to be an FNH into a hepatocellular adenoma. So we postulated that one of the reasons why these new case reports were reporting higher rates of ISOTA hyperintensity was because these case series had done the molecular subtyping and our primary studies had not. And even the one study that had done the molecular subtyping had only done it about 1/3 of their patients, and they did have a lower specificity ranging from to just below 90%. So that was...
So I think what you're saying is that the actual basis of the classification changed during the accrual period of the studies you analyzed. And so the same image in the same patient at 2 different points in time might have been classified differently. Is that correct?
Exactly. So in 2005, some pathologists in Bordeaux came up with this classification scheme. Obviously, it took some time for it to be disseminated and accepted. And only in around 2011 did the WHO endorse this new classification scheme. So many of these studies had accrual phases in the sort of mid to late 2000s and were published anywhere from 2007 to 2011, and obviously might not have incorporated this very novel information into their classification. So it's a good example of evolution of disease, how things that we used to classify one way are reclassified and might change our way of thinking about things.
Well, as we're getting more experience with genotyping diseases and their subcategories, I think this issue that drove the results in your paper we're likely to see again and again, because many diseases that we've recognized are in the past based on their pure histology are now being reclassified and subclassified based on their genotypes and molecular expression. So it's, I think, a very, very important concept. Now, what was the actual quality of the studies that you looked at? You used the Quaddis 2 scale, and how does that actually help?
Well, the Quadus 2 scale is a way to rate the quality of diagnostic accuracy studies, and it can be applied in systematic review. So you look at factors like, is your patient group likely to be representative? So did they cherry pick certain cases, or was it a consecutive or random sample of patients? Other things are, was the reference standard done at a time interval that's deemed appropriate to accurately classify the disease? Or, for example, was your MRI done in 2005 and your pathology done in 2011, where things might have changed?
Right.
And the other main factor here was the reference standard applied. Was the description of the reference standard sufficient, and was it likely to classify the diseases that you're looking for? So in our case, it was a very useful tool in that we found many areas where there was a risk for bias. We don't really say it's high quality or low quality because that's really in the eye of the beholder, but there were areas that provided opportunity for a high risk of bias, particularly in the area of the reference standard, because often studies didn't describe whether they did molecular subtyping because they probably weren't aware of it because it wasn't standard of care, but back when they published their paper, or when they did describe it, they hadn't done it or had not done it on their full patient population. So it really provided a way to categorize the areas where we thought the studies were maybe at high risk of bias and to identify how those differences contributed to the differences in outcomes.
Okay, now, what do you think are the next steps? What needs to be done now, and how should readers use this information? Do we sort of like put a halt on categorizing these? Do we ask for the genotyping? What actions should we take that are different?
I think that's a great question. There's a few things that are going on in parallel. One is probably most pathologists who specialize in liver disease will be incorporating this new classification into their practice, and we need to be aware of that as imagers. I'm not sure that we need to stop using gadazidic acid for classification of hepatocellular adenoma versus FNH, but it might be nice to see some studies that either reanalyze their data in some of these larger trials with molecular subtyping, if that's possible, or trials that look at whether gadazidic acid provides an advantage over conventional MRI, because no one's really looked at that directly. Is gadazidic acid in the hepatobiliary phase adding an advantage to your conventional extracellular agents? So that would be a good question. And I think if you're out there practicing and you see these cases, you at least have to be aware that the inflammatory subtype could be a false positive for the diagnosis of FNH. So if you see something that's ISO to hyperintense and looks for all intents and purposes like an FNH, if that patient has risk factors for an inflammatory hepatocellular adenoma, whether that be obesity, alcohol use, diabetes, there's some metabolic syndrome. So if that patient has risk factors for the inflammatory subtype, we should maybe think twice about confidently diagnosing an FNH based on MR features alone. Now, nobody knows exactly what to do with these patients, and I think that's an area for discussion. But one strategy postulated has been to follow these closely, take away any estrogenic agents if those are there, and see whether or not they shrink. And if they don't get smaller or they grow, then there's a role for either surgery or biopsy. And I think this question is really evolving, but I think the take-home message is have some caution in relying on MR features alone and think of the patient context. Are they at risk for having this subtype? And I think a good multidisciplinary discussion with your hepatobiliary surgeons, your pathologists, etc., will be a good way to not miss these lesions and not call them FNH when maybe they shouldn't be.
Thank you. Thank you. It's very, very interesting. And thank you very much for joining us on a very stimulating discussion.
You're welcome. It's been my pleasure.
Bye-bye.
Bye.
Hello, I'm Alex Dank here, and I'm Deputy Editor of the journal Radiology, in charge of thoracic imaging. Welcome to this podcast. Today's guest is Dr. David Yankelevitz from Mount Sinai Hospital in New York, and we will be discussing their recent article, CT Screening for Lung Cancer, Non-Solid Nodules in Baseline and Annual Repeat Rounds. Welcome, David.
Thank you very much for having me.
David, obviously this is another interesting study that comes out of your LCAP Early Lung Cancer Action Program. Can you give our readers a brief explanation about this program and maybe tell how this program is different from other big lung cancer screening programs like the NLST or other programs in Europe or in Asia?
Well, the International Early Lung Cancer Action Program is a prospective cohort study that enrolls institutions who are willing to follow a common protocol, submit their data in an ongoing way, clinical data as well as imaging data, to a central repository. And we currently have 70 some odd institutions in 8 countries around the world that have contributed data to us in an ongoing fashion. And it allows us to continually monitor and upgrade management protocols.
Okay. David, in this recent study of your group, what were the main findings? What were the main results?
The main result of this is that non-solid nodules can be followed on an annual basis safely. And this was, I think, a very important finding for us because it allows us to manage these types of lesions in a very conservative way, even though we recognize that some of them may be cancer. So it's really an example of what we've talked about frequently in the literature about overdiagnosis or indolent types of lesions, that we're now getting to the point where we're making recommendations that in fact we can be safe with following them, and we're giving sort of guidelines as to how to follow these types of lesions in a safe manner.
I see. So citing from your results, you identified a little bit about over 4% of nodules at the baseline screening as adenocarcinomas, I mean 4% of those non-solid nodules. And at the repeat round of screening, this rate was below 1%. You're talking about the diagnosis in your paper, biopsy, surgery. What were the morphological criteria that triggered the workup of these nodules?
This is these non-solid nodules are really a challenge because it's very hard to see if they're growing or not. And so in general, the main trigger for them being worked up was there were criteria for morphologic size would trigger follow-up scan. So we would do a follow-up scan at 3 months or 6 months and look for growth. And then depending on growth being overall size of the nodule increasing or the development of a solid component. And those were the things that mainly triggered further invasive procedures. But there was a lot of leeway in these non-solid. These lesions have been very hard to define, and it's very hard to get people to follow a specific protocol. And we've seen that not only in LCAP, but in NLST and other studies as well. There's so much uncertainty about these lesions that so we in many ways we're fortunate because some of these cases were followed for a long time, even though they were showing some very slow growth. So we have the advantage of actually seeing that.
I would like to address another potential leeway. There is increasing evidence in the literature that even experienced radiologists have a very hard time for some challenging types or manifestations of these nodules to allocate them to either the solid or the part solid group. And we know from different studies that experience doesn't help. So what does help, and how secure are you in allocating these nodules to a specific group from which then flows management recommendations and so forth?
You're hitting on a very touchy subject. You're right. There are very poor criteria for how we define solid, non-solid, and part solid, and how you say something is moved from one to the other. It is still fairly subjective. I think the obvious cases are obvious, and the less obvious cases are, as they'd say, less obvious. Nobody has a criteria for example, how much of or what percentage of a part solid it has to be before it becomes solid. Is it 60%? Is it 80%? There is no firm definitions. And similarly, you can show the same non-solid lesion to one person who says, you know, this is developing a solid component. So there is a bit of subjectiveness to it. I can tell you, though, that we do put something in our data forms. You know, everybody is required to say solid, non-solid, or part solid, and I guess they just take their best estimate of it. But this is ultimately going to have to be defined in a better way.
And in a better way, you mean by that in a quantitative way?
I think everything is going to move into more quantitative. I think the important thing here, though, for this paper that is reassuring is that even when nodules, whether you know, the obvious ones are pretty obvious that they're non-solid. Although even in those non-solids, many of them have microinvasion, meaning that it's invasive and we're just not seeing, you know, the radiographic manifestations because it's not large enough. But the important thing is that whether they become part solid, that even the part solid ones have such a good long-term survival that whether or not we missed it being non-solid or part solid when it's still relatively small, I think it makes no difference from a prognostic point of view. So that's the reassuring part of this.
I see. David, another aspect of your study that I would like to briefly address, obviously the results and the conclusions come out of a lung cancer screening context. This context is unique in that the patients come back every year, and you're pretty sure about that. So making recommendations, drawing conclusions from that, you can feel relatively at ease to be, you know, more generous. How do you think or how do you envision, can you translate these results from a screening into a non-screening context? Very more precisely, what I mean to say is, you know, that currently for the subsolid nodules, non-solid nodules, when we see them in the clinical context, there is this recommendation for a 3 months follow-up, which is less generous than the screening recommendations that you make. How do you think will your findings, or can your findings, translate from a screening context into a more clinical context?
Well, I think that the 3-month follow-up is somewhat for a sense of reassurance for people. I think that I consider if the people, whether they were in a screening program or they had sort of incidental screening, and they were in essence eligible for screening or a high-risk person, I tend to think of the management should be the same for both. That in essence they're prognostically basically the same, whether they were screened or just incidentally found. If there are other clinical indications for the person having the test, that has to always be considered. The 3-month follow-up versus the 1-year follow-up is a tough question. It's hard, you know, and I've spoken with several of the Fleischner people about this because it's very hard to tell people you have something, it may be cancer, but come back in a year. It's very difficult to do that. On the other hand, what do you get by doing it in 3 months? Well, one of the things you might get is if it wasn't done in the screening context, it might not have been done with the proper technique, with thicker sections, and you might not see certain things that you would see with the thin section. So that is an advantage to doing it quicker there. I think it's pretty rare, though, that you would see something, if you had a good scan. I think the 3-month follow-up is unlikely, really unlikely to show anything at 3 months that would change rather than waiting a year.
Unless
so I doubt,
Unless the nodule disappears, of course.
Unless the nodule disappears, which actually happens in a fair number of cases. And especially when they're, well, especially in the annual round, it's even more frequent. But on the baseline round, yeah, they can disappear, and that can offer people a bit more reassurance quickly. But if they stay there, then you're going to repeat the scan again.
Yeah.
It comes down to utilization, too.
David, you, you briefly alluded to the technical issues that are related with the detection of these nodules. Obviously, this is the context of low-dose CT CT protocols that were originally designed for detecting solid lesions, solid nodules. Do you think the low-dose techniques that we have today are good enough to detect all of these subsolid nodules?
No. I think this is an interesting dilemma that we have. You know, with the push more and more towards finding, to lowering radiation dose, and you know, and it's a worthwhile thing to do. These subsolid nodules, and especially the non-solid ones, do become more difficult, much more so than solid lesions. The noise really can make them invisible, basically. And so there is a challenge. And similarly, some of the new algorithms for noise reduction can take non-solid nodules and kind of make them disappear. So that is a concern. Fortunately, again, these are, you know, if you're going to make any of the lesions disappear, you probably want to make these, you know, the ones less apparent, because they are so indolent relatively. But it is a concern, and especially the smaller the size, the more non-solid appearing they are, the more chance you can have of making these things disappear. So all of these things play a role. It's always this sort of, you know, weighing, you know, risk-benefit analysis of lowering the dose, but potentially missing certain lesions. And the idea of integrating, you know, what level of quality do you want versus what level of dose or scanning protocol do you want to use?
I see. David, my last question to you: when we go out into the world of general radiology, we often receive the echo of a kind of confusion, you know, the programs, the guidelines, the screening context, the non-screening context, guidelines for different categories of nodules and so forth. What is the take-home message from your article to the general radiologist?
I think the take-home message here is that these nodules can be managed safely at 1-year intervals. That had we treated any of these nodules prior to when we actually did treat them, say when they're 2 centimeters, had we treated them when they were 1 centimeter, there would have been no survival or prognostic advantage to the patient, because all of them were 100% long-term survival. And similarly, when they converted from non-solid to part solid, and we did that at annual basis, when we saw that and operated even then or treated them at that point, there was still 100% survival. So that made it, that gives us confidence that following these on an annual basis is a safe thing to do. If I can continue, it also really brings us into a whole new world of management, because, you know, many of these non-solid nodules, ultimately, if you keep following them, they do progress over time. It might be 10 years, it might be 15 years when the non-solid nodule ultimately gets to a point where you're going to say, hey, time to operate. You know, this thing's starting to look bad, let's operate. And so then you really have a question, there's a dilemma that clinicians really now need to face, and it gets into this whole concept of shared decision making. So if you tell a person you have a non-solid nodule, it may progress, it may be 10 years from now. So the question really still is, well, should we operate or do something now when you're healthy enough to do something versus 10 years from now when you may be less healthy? So, I mean, there's a lot of considerations that really come into this, and I say it really is a shared decision-making kind of context.
Okay.
So I think that's...
Yeah. David, thank you very much. And we're looking forward to reading soon more from the interesting funders of results from the ILCA project. Thank you for being with us today.
Thank you. I appreciate it.
this is Albert de Roos. I'm Deputy Editor for Radiology on Cardiac Papers, and I like to discuss today an interesting article which will become published very soon, entitled The Influence of Cardiac MR Imaging on DNA Double-Strand Breaks in Human Blood Lymphocytes. This has been a controversial subject over the last few years, and I'm joined by the first author of this paper, Dr. Michael Brandt, from the Department of Radiology at the University Hospital in Erlangen. Welcome, Dr. Brandt.
Thanks, nice to meet you.
Thank you. So I like to discuss this paper in a structured way, and I think it would be helpful when you first explain a little bit the background and the motivation for this study, because not everybody will be aware of the controversy about these double-strand breaks which may occur after cardiac MRI. Can you explain that in a little bit detail?
Yes. The idea for the paper starts in 2013. In this year, a group of Switzerland noted that they have obtained DNA double-strand breaks after cardiac MRI, but that was surprising because previous published papers showed no effect of MRI on human blood lymphocytes. So the aim of our study was to show if there are really DNA double-strand breaks after cardiac MRI, or if cardiac MRI is still a safe method for cardiac imaging.
Okay, so that was this other paper who triggered your interest, and
Yes.
you are working in a laboratory in your department where you are familiar with these immunofluorescence techniques and immunofluorescence microscopy to study these double-strand breaks. So it would be helpful when you can explain a little bit this technique, which is not familiar to many radiologists. What is actually the method? How works the visualization? And how observers are grading those images? Can you explain that a little bit?
Yes. The method we used is based on the gamma H2X immunofluorescence microscopy. This method based on the early phosphorylation of the histone variant H2AX. One of the first reactions of a cell to a DNA double-strand break is the phosphorylation of this histone variant. This phosphorylation takes place within 1 or 2 minutes, so it's a very, very early reaction of the cell. And now, with a primary antibody and with a special second antibody with a linked fluorochrome, we can make this phosphorylation visible under the immunofluorescence microscope. And now we take the samples, and after the staining of the samples, we look under the microscope, and now we count the DSBs, that are the double-strand breaks, within the cells, and then we can calculate maybe there are 0.1 DSBs per cells. We have two persons to do the counting of the cells independently, and they are also blinded, and we will do this immunofluorescence microscopy since 11 years now, and the gamma H2X immunofluorescence microscopy has been proven to be a good method to detect also small amounts of DNA double-strand breaks, which has been proven in many previous papers.
Okay, so can you comment a little bit about the importance of observer variation here? Because that may be an issue in general.
Yeah, that's true. And therefore, because everybody counts a little bit different, somebody says, well, that's a double-strand break. The others say, no, that's not a double-strand break. And therefore, we have two independent observers. Each of them counts at least 3 times one slice, and then we form a mean so that we can say, okay, it's not just this the person number 1 who say, well, there are DSBs, or just the patient, the person number 2. There's always a comparison of the results of person 1 and the person 2 to get a good result.
So it's important to exclude some subjectivity in this assessment.
That's right.
And it's also important to understand what these double-strand breaks actually mean and how they develop in time. Because what is the timeline when you perform a CT or MR study that this may happen. Can you comment on that?
Yes. So DSPs are regarded as the most severe damage to the DNA. And as previous papers have shown, the DSPs, for example, if you have X-ray radiation, the DSPs could be obtained, or you can see the DSPs at least 5 minutes after X-ray examination. So the X-ray stops and also the induction of DSPs stops. Then you have 1 or 2 minutes, which you need 1 or 2 minutes for the phosphorylation of the histone variant. And after 5 minutes, you can see the highest peak of induced DSPs. This has been proven in previous papers. So 5 minutes after, for example, X-ray exposure or something like that has been proven to be the best time point to see the highest level of DNA double-strand breaks. And therefore, one has to assume that also after MRI, the 5 minutes value after the MRI examination is the best time point to obtain induced double-strand breaks.
Yes, that's what you actually did. So the MR study lasted for 30 till 60 minutes, and 5 minutes after stopping the examinations, you draw the sample. Was it also specified in the other paper how that was done?
No, that was not specified. In the other paper, there were no hint when the blood samples were obtained, and they also didn't tell us if they or how long the MRI lasted, and they also didn't tell if they obtain the blood samples 5 minutes, 10 minutes, or 60 minutes after their MRI. So we do not know when the other samples were obtained.
Okay, so, and we discussed the methodology, how you analyze the samples, and what were the actual results, and how many patients did you study?
Okay, we have more patients than the private study. We have 45 patients, and we also have different subgroups. We have 29 patients with a myocarditis protocol. We have 10 patients with a stress testing protocol, and we have 6 patients with flow measurements and angiographic procedures. And neither in group A nor in group B or C, we could obtain any increase of DNA double-strand breaks after cardiac MRI.
Yes, and then you discuss issues in contrast to the previous study about somewhat unusual values of DSPs at baseline and at follow-up. What were the technical issues here? Can you comment on that and how that differs from your study?
Yes. In the previous published paper of the group of Switzerland, they have a very large range of DNA baseline level, a DSP baseline level. The DSP baseline level is the normal amount of DSPs in your cells. Everybody has DSP according to natural radiation and also to oxidation within your body. But this baseline level is between a very small limit. But now the study of the paper or the study of Switzerland have a large range in these DSPs. And this could be a hint that there is a misinterpretation of sustaining, or that's a failure in sustaining. In our paper, the DSP baseline levels are in range, are in these borders. So we are in content with many previous published papers so that we can say, yes, our staining was right and we have done the staining correct.
Okay, so you think your methodology by using different observers and by obtaining values in accordance to the literature show a more consistent result what to expect. But can you also come up with some limitations of your own study? What should be studied in better detail, or is everything now clear?
No, of course there's a limitation in our study. So one thing is contrast media. We do not know if contrast media may induce any DSPs or something like that, but in our study every patient gets contrast media because it's necessary for the cardiac MRI. And therefore, we cannot differentiate between maybe effects without contrast media and effects with contrast media. So a next step would be to evaluate MRIs without contrast media to MRIs with contrast media to show if there's maybe a protective effect of gadolinium or something like that.
So what do you expect from contrast media? Contrast media are under scrutiny because they may accumulate in the brain, may have unexpected toxic effects. What do you expect what gadolinium will do to these DSBs?
In my opinion, I don't think that they will have any effect on the DSBs.
So an X-ray contrast agents may have some effect, I think.
That's true. That's true.
Yeah, but gadolinium has not that same effect.
No, I don't think so.
Okay. So what was the actual conclusion from this study? When you summarize your results, what is the take-home message we have to conclude from your study?
So the take-home message is that cardiac MRI is still a safe method for cardiac imaging without the risk of inducing DNA double-strand breaks.
Okay, I think this is a clear conclusion, and this concludes this discussion. Thank you very much.
Thanks, you're welcome.